French Cancer Center. I logged in from two accounts.
Yeah, it is in French National Contour, something like that. Okay, but it's a French system basically. French Federation of Cancer Centers Sarcoma Group. Okay, so what it includes? Hello,
She is.
am I audible?
She is logging and joining, ma'am.
Ma'am, am I audible?
Yeah, you're audible.
Okay.
Am I audible?
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Yeah, your screen is visible. Tell me about the grading.
Ma'am, it is the FNCLC grading. It includes the tumor differentiation, the necrosis, and the mitotic count. And
What is tumor differentiation?
Ma'am, it is graded from 1 to 3. It is well differentiated, moderately differentiated, and poorly differentiated. And
what is well differentiated, Avneet?
Ma'am, the tumor tissue that is resembling the parent tissue, the normal tissue.
Yeah, normal adult mesenchymal tissue, whatever is resembling. Yeah, next.
Ma'am, then the
moderately differentiated means?
Ma'am, it has some similarity to the original tissue.
But histological typing is uncertain. Certain. Okay, histological typing is certain. Very few resemblances are there. And which doesn't resemble is
type 3.
Poorly differentiated. Yeah. So what are the examples for grade score 3 of tumor differentiation? Can you give me 2 examples? Which are otherwise also like very high tumor differentiation.
Ma'am, pleomorphic sarcomas and synovial sarcomas, rhabdomyosarcomas, pleomorphic with less than 5% differentiation.
Embryonal,
yes,
okay, synovial, these are more common. Okay,
yes.
Then mitotic count.
Mitotic count is also from score 1 to 3. All of them are score. This is also 1, 2, 3. If we see it in the high power field, if it is 0 to 10, 10 to 0 to 9, 10 to 19, and more than 20 mitosis per high power field.
How many high power field?
50.
Okay. Yes. Okay. No, not 50. It's wrong.
10 high power field.
10 high power field. Okay. Yeah. Next.
Then necrosis, ma'am. So if it is no necrosis, then it is score 0. If it is less than 50%, it is score 1. More than 50% is score 2.
Okay. Now final grading based on this?
The final grading is, ma'am, dependent on the score that we've added all of them. It can be grade 1, 2 or 3. 1, 2, 3 is grade 1. 4 and 5 is grade 2. 6 to 8 is grade 3.
Yeah. So, and any other system, grading other than FNCLC?
Enneking also had a grading system, ma'am.
Enneking is for musculoskeletal. I mean, it's more for intracompartmental, extracompartmental bone. It is. I'm asking for soft tissue.
NLH, ma'am. NLH staging.
NLH, National Cancer Institute staging. Okay, which included histology and amount of necrosis. It did not have mitotic count. Okay. So yeah, so in NCI grading system, no, National Cancer Institute, again they classified into grade 1, grade 2, grade 3. Okay, depending upon the necrosis and the type of the tumor. In that also the higher grade were this PNETs, alveolar soft tissue, rhabdomyosarcomas. Whereas grade 1 were liposarcomas, okay, DFSPs and all. And grade 2 were intermediate like pleomorphic, MFH, leiomyo, all these things. Okay. And necrosis was 0 to 15% and more than 15%. So it was no necrosis in grade 1. Okay. This was NCI grading system. Okay. Next, what do you want to see in histopathology?
IHC we can put if if you're having some doubt in the.
Yeah, IHC. What do you want to see, do in IHC?
Ma'am, we want to find out what sort of tumor it is, especially if it is a round cell tumor, then we want to further put further IHC to differentiate the kind of tumor we are dealing with.
Any examples you can give? One IHC of?
Ma'am, we'll put CK, we'll put Vimentin, we'll put Milan, we'll put S100. There is
HMB45, S100, Vimentin, Actin, Myosin, Desmin. Okay, these are all the things. And okay, fine. Now you tell me, like extremity sarcomas, what is like any presence of node is with stage?
Stage 4 now.
Any presence of metastasis or node is stage 4.
No.
Okay. Grade 2, grade 3 will be minimum of stage?
3, ma'am.
3 or 2?
Ma'am, T1 is T1 is stage 1 and 2. If T1 is with grade 1, then it is stage 1. If T1 is with grade 2 or grade 3, then it is stage 2. If any T2 or T3 is in stage 3.
Yes. Okay. Yes. So any N1 is stage 4.
Stage 4, ma'am.
In extremity sarcomas, what is T1, T2, T3, T4?
Less than 5 centimeter, 5 to 10 centimeter, more than 10 to 15 centimeter, more than 15 centimeter is 1, 2, 3, and 4.
Okay. N and M are self-defined. Okay. What about any difference when you come to head neck soft tissue sarcomas?
Ma'am, in them nodal status I think is stage 3.
Head neck is like head neck staging only. Okay.
Yes,
less than 2 to 4, more than 4. Okay. Adjacent organ and inoperables. Okay. So that is like T4B. Same like head neck staging. What about abdomen?
Ma'am, in them also the nodal staging will make it stage 3.
Sorry?
Ma'am, in retroperitoneum also, abdomen also, presence of nodal staging will be stage 3.
Yeah, stage 3. Okay. And anything difference in T staging? Retroperitoneal में क्या होगा? So if it is organ confined, it is T1. Okay. Anything beyond organ confined and invading serosa or visceral peritoneum will be T2A. Okay. If it is beyond the serosa or invading the mesentery and all, it will be T2B. Okay. And T3 will be like other organ involvement. And T4 will be like multifocal involvement. If it is less than 2, 3 to 5, more than 5. Okay. T4AB. These are like for abdomen.
Abdomen.
Okay. And other part is gist. So gist is again 2 to 5, 5 to 10, and more than 10.
Yes.
Okay. And just has its own this armed forces criteria. No? So you have to remember that. Okay. So what else? Sarcomas. That's it.
Extremity,
Then,
ma'am. T1, T4, grade 1 will be stage 1, na?
T4?
Grade 1.
Yeah, 1B it will be. 1B. Okay, T4 grade 1. Yeah. Then what will be the, based on your, this one, what are the prognostic factors for soft tissue sarcomas?
Ma'am, if you have done the surgery, ma'am, most important is the grading. And if you have done the surgery, the margins of the tumor are the most important prognostic factor.
Yeah, staging as well as the margin. Okay.
Yes.
So fine. And what will be the anything related age or site also is important. Okay.
Okay.
So and apart from this, did we leave anything? Yeah. In what solution you will send for histopathological examination?
Formalin.
10%
Correct.
formalin.
Formalin.
10% buffer.
10% formalin.
10% neutral buffered formalin. Okay. Then right. So now, can you tell me in case of in imaging, what do you want to do? First, starting imaging क्या है? उसके बाद क्या करेगी?
Ma'am, first of all, we'll start with doing a X-ray of the limb with a joint above and joint below,
Okay.
because we want to make sure that we're not dealing with a bony swelling if we are having any clinical doubts, that if it is a bony swelling or a
Okay.
soft tissue
In case
swelling.
of a clinical doubt, but your examination more so it will confirm whether it is a bony swelling or a
Soft tissue swelling.
soft tissue swelling, and your presentation also. So most of the cases in a soft tissue, what will be the first investigation?
MRI.
Yes, Abhi, if you want to do ultrasound?
No, ma'am. Since we're doing an MRI, doing an ultrasound, we can do an ultrasound to find out the origin of the tumor, the plane of the swelling, if there are any regional lymph nodes or not. But since we're doing MRI, it should tell us all of these information.
Yeah. So ultrasound is the first investigation, but it is not confirmatory investigation. Okay. For the staging workup, you will need an MRI. Definitely.
Ma'am,
Okay.
should we
So,
say, if we are not prompted, should we say ultrasound regularly in our exam?
that's why if you classify, no, he will not object. Okay. Just thing is that even in under ultrasound guidance, you can do a biopsy. Is it not?
Yes, ma'am.
So, and ultrasound is easily available. MRI is not available. So, to delay the time interval between the biopsy and treatment, I would like to know the origin as well as do a guided biopsy under ultrasound guidance. You can tell. Okay.
Okay,
So
ma'am.
there are now 3D, 4D ultrasound, this one also available here. So you can do, okay, as a first investigation to save the time. But your confirmatory staging workup for the local spread will be always, local regional spread will be MRI.
Okay.
So why not CT?
Ma'am, we can consider CT, but since soft tissue delineation is better appreciated on MRI, I'll prefer doing an MRI.
Yes. So if you want to see the vascular delineation, what additional you want to add? Suppose it's close to neurovascular bundle.
Contrast MRI.
MR angio can be done. Okay. MR angio can be done. Then okay, fine. Then suppose what are the findings that you will see in an MRI? Okay, in MRI to characterize it as malignant lesion.
Ma'am, malignant lesion will often be irregularly shaped hyperintense lesion, which will have mostly pushing kind of mostly confined to one compartment. It can also be associated with other compartments, but mostly a pushing kind of a growth in one compartment. And
so MRI mein there are something, no, T1, T2, heterogeneous.
yes, ma'am.
Process.
On a I'll prefer doing a T2 weighted image, so I can see its relation to the neurovascular bundle. And
T1 hypointense, T2 hyperintense.
If you want to
T1.
specify more,
T1, what appears right on one. Yes.
if T1 weighted, okay. If you want to specify more, like in an MRI, if there is availability, which images will you prefer?
Coronal images. Axial images, ma'am. Axial images.
नहीं, that's नहीं.
T1
There is something in MRI also, not even T2 के
T1
अलावा
fat
कुछ है.
suppression. T1 fat
Sequences.
suppression.
हाँ.
Fat suppression.
Yeah. Stereomate.
T1 fat suppression.
Yes. Diffusion weighted imaging. Fat suppressed. These would be more. More defined. Okay. अच्छा. Question I forgot past. When will you refer a soft tissue swelling to higher tertiary center?
Ma'am, any swelling that is more than 5 centimeters deep to the deep fascia or recurrent swelling, I will like to refer that patient to a experienced center.
और भी है.
Pain.
Anyone?
Pain, ma'am.
Yeah, pain. Yes.
Recurrence.
Recurrent you told.
Increasing in size, ma'am.
Ma'am, rapidly increasing in
Rapidly.
fascia.
Pain more than 5 centimeters, deep seated, rapidly increasing in size, and recurrent. Okay, these are 5. Yeah. When will you do like in a retroperitoneal sarcoma? Is biopsy done on routine basis?
No, ma'am.
No. So when will you do biopsy in retroperitoneal sarcomas?
Whenever we are planning for some sort of a non-operative intervention first or a palliative intervention, and we need it for confirmation of the biopsy.
So if they are inoperable, generally inoperable in the sense they are adherent to vital structures, and you cannot give. What is the most important retroperitoneal sarcoma prognosis factor?
R0.
So if you cannot give R0, okay, then you will not operate. Okay. So in that cases, or when you feel that it is metastatic tumor or some imaging is discordant, right? Very deep-seated tumor. Neoadjuvant concept is there in retroperitoneal sarcomas. Who is this spread up?
कुछ में RT देते हैं ना मैम आजकल RT neoadjuvant RT.
Neoadjuvant RT is very rare, but RPS में ideal is surgery. Okay. So otherwise it is considered like not operable and treated to just control the disease. Okay. So chemo is not there. Okay. Neoadjuvant chemo is not there. Then
Madam, I just wanted to ask, what was the question to the previous discussion? The answer was the pain more than 5 centimeter, rapidly increasing size.
It's a UK criteria.
when will you refer a soft tissue sarcoma swelling tertiary center? I mean subpropose.
Yes, ma'am.
Red flags.
Okay.
Warning
reference.
signs, yes, ma'am.
Okay. Yeah. So how many cores you will take?
6, I think.
6 to 8 cores. Okay.
Yes, ma'am.
Yeah. Minimum 4 should be taken. So if it is and you'll also send it for RNA DNA analysis, karyotyping. Okay. The
Yeah.
frozen tissue. Okay. So in case now you tell me what all you will see. You want to see in a T1 weighted image. So what all you will see? Is
Ma'am,
this T1, T2?
Ma'am, it is a T1 weighted image since the blood vessel is appearing white.
T1 with contrast.
Okay.
T1 with contrast. Ma'am, on a T1 weighted image, I would like to see the compartment in which the lesion is situated, where is it arising from, and what tissues are involved. Is it intracompartmental or has gone beyond the extracompartmental? What is its relation to the bone? What is its relation to the neurovascular bundle? What is its relation to the skin? Is there
Anything
any
else?
edema is there or not?
Anything else?
Skip lesion.
Skip lesions, yes, ma'am.
Anything
But I
else?
think
Nodes, joint.
marrow. Bone marrow.
Anything else?
Nodes, joint.
You will also see if there is any necrosis. Okay, that will characterize. So presence of necrosis will be high grade.
Yes.
So aggressively growing tumor. Apart from what all you told, neurovascular bundle, bone marrow, the crossing of the compartments, okay, whether limb salvage is possible or not, okay, any fracture is there,
Yes.
okay, if it is bone given, okay. So then satellite lesion, okay, fine. Then what about metastatic workup?
Ma'am, if it is not the tumors which usually metastasize to the lymph nodes, I like to do I can, depending on the my availability, I can do either an X-ray chest or a preferably CT chest. Or if the tumors also metastasize, these are one of the tumors that metastasize to lymph node, I'll also like to do a CT of the abdominal pelvis.
So X-ray, for which tumors you can avoid X-ray?
For low-grade tumors and tumors less than 5 centimeters, we can avoid.
And superficial tumors.
Superficial tumors. Ma'am.
So for which tumors X-ray is not preferred, you have to do CT.
High-grade tumors, ma'am.
High grade? More than
5 centimeters, ma'am.
5 or 10?
10, I think.
10, okay?
10 centimeter.
10 centimeters, okay? X-ray for can be avoided for less than 5 centimeters, superficial tumor, okay, which are low grade. Whereas X-ray can be done between 5 to 10 centimeters tumors, okay, which are low grade, which are otherwise higher grade or intermediate grade, and little deep seated, okay. Whereas for high grade tumors and differentiated, means poorly differentiated tumors and more than 10 centimeters deep seated tumors, you would like to do a CT chest, okay.
I had a question. When we say these criteria, these are all criteria, or they like any one of them, or there should be all of them? Any one of them, right? If it is even a small tumor with a high grade, we have to do a CT, right?
Yes.
Yes. Okay.
So grade is the most important thing. Next comes size.
Yes.
Okay. So will you do a contrast CT thorax or?
HRCT thorax can do, ma'am.
Yeah, low dose non-contrast will suffice.
Yes.
Okay.
Yes.
So you will do a CT abdomen in cases of where we discussed. Okay, if it is liver mets. Okay, myxoid lipocell, round cell liposarcomas, myxoid liposarcomas, all these are prone to go to liver. So in those cases, you will do CT abdomen as well. What is the role of PET CT?
Whenever we are planning to do a neoadjuvant therapy for a patient like a Ewing's or a rhabdomyosarcoma, ma'am, then we preferably take a PET CT before starting the therapy so we can do a response evaluation.
Okay, if in a PET CT, is there any use of PET CT in Ewing's sarcoma?
Yes.
Yes, what is that?
In Ewing's sarcoma, we have
Yeah, so you do a marrow biopsy if you see marrow involvement on a PET CT. Okay, so then next question, investigations.
Madam, would it be correct to ask Neet whether she would consider a PET CT in this case?
Depends on the biopsy of the tumor.
Can I know the biopsy report?
Ma'am, it was a leiomyosarcoma. High grade
leiomyosarcoma. So leiomyosarcoma comes under grade?
High grade. It's not.
So NCI grade में grade 2 जैसे आएगा. Okay, leiomyosarcomas. Okay, intermediate grade.
Ma'am, is there any role for routine PET, ma'am, in soft tissue sarcoma?
No. PET CT can be considered only if you think like it will change the management. Otherwise, a CT thorax would. Where does leiomyosarcoma spread?
Lung.
That's it. You do CT thorax. Okay. Non-contrast CT thorax.
Madam, considering this is a recurrent disease and we do not know about the last intervention, so and no adjuvant therapy after that. So in that class, should we consider in terms of recurrence? Should we consider PET CT?
Can PET MR be the single investigation to be done, madam?
PET MR?
Available.
How many institutes have
PET
environment?
cannot replace the
पूछा तो।
MRI because we need the loco-regional most.
No,
Ma'am, that's it.
even in recurrent setting, okay, once you get the biopsy done, just see if it is the same histology which they have removed, or if the documents are not available, if they are intermediate grade or low grade, okay, most likely site of spread, if it is covered, that is enough, okay. So need not necessarily in all recurrent cases I will do PET, not necessary.
Ma'am,
Okay.
Devita suggests one line, ma'am. They suggest if the identification of unsuspected sites of METs, then only consider for the PET scan.
Yes, yes. So in case of leiomyosarcoma, you know it is lung. So non-contrast CT thorax will suffice. Okay.
Lung में मिला तो करेंगे क्या मैम? Like in CT chest there is METs, then we will do or
Yeah. Does it actually alter your management if you have found any lung mets with
Ma'am, if it is a synchronous METs, I want to see the nature of the disease.
yeah, whether they're single or manageable by surgery, solitary mets.
we will also see na कि extrathoracic some lesion are there or not.
Yes, ma'am. If the
That's
ma'am,
what in metastasis, if initial site of metastasis has any means first of metastasis has any metastasis, then you can think of, but otherwise not needed. Okay, PET is not indicated. Okay, next. Yeah, so preferred modality, high grade, okay, provided, or 5 to 10 centimeters, even synovial sarcomas or pleomorphic sarcomas or rhabdomyosarcomas, you will still consider for chemo. What are the chemo drugs given?
ma'am, we give adriamycin and ifosfamide and mesna for ifosfamide and dacarbazine.
Tell me the regimens.
MAID regimen, ma'am.
Made, okay, one. Then
MAS is also, I think.
AIM, made, MAP, okay. These are the regimens.
Ma'am, when it
Pemetrexed.
comes to Ewing's, then VDCIE is something that specifically we give.
Ewing? It is ifosfamide and epirubicin.
Yes, ma'am.
VAC-IE will give.
Yes,
Okay.
yes, ma'am.
Vincristin, acnomycin, and ifosfamide, epirubicin. Okay.
Yes.
And okay. So in retroperitoneal sarcomas or in soft tissue sarcomas, do you know any targeted treatments?
Tyrosine kinase inhibitors are given, ma'am.
Okay. Any drugs?
Regorafenib, ma'am.
Trabectedin used. Trabectedin can be given. Yes.
Trabectedin.
Okay. So trabectedin. In GIST, of course, all the you will try all the TKs. Okay. So any hormonal treatment in any kind of tumor?
DFSP you told me.
Yeah. And ALK inhibitors in any specific soft tissue sarcomas? Inflammatory myofibroblastic. Okay. Crizotinib and all are used. Okay. Yeah, fine. So we discussed last time about the rearrangement and genes, so I'll not that they are important to consider for the targeted treatment. Okay, so that is important. So now tell me surgery. Okay, last we'll consider first all the surgical aspects and then we'll close. So surgery, what is Enneking classification of margins?
Ma'am, Enneking defined classification of margins as 4 kinds. It is intralesional. It is margin when we're going intralesional, marginal, wide excisional, and compartmental resection. if we consider the tumor to be a pushing kind of tumor, and if we are if we are taking the tumor margins inside the reactive zone, then it is an intralesional kind of excision. When we are taking it in the marginal zone, then it is a marginal kind of resection. If we are dissecting it with a 2 centimeter margin, it is a wide excision. When we are taking that entire compartment from the origin to the insertion of tumor, all the muscles in that compartment, then it is compartmental resection.
Okay, fine. So, how does this matter actually, like with respect to soft tissue sarcomas?
Ma'am,
So, what margin?
your voice is more there.
So, if it is a benign tumor or if it is a malignant tumor, when will you prefer which zone you would like to take?
Ma'am, when it is a malignant tumor, I'll either like to intralesional and marginal are not therapeutic. We either go for a wide excision. Basically, the chances of recurrences will differ. It is 100% recurrence in an intralesional, 90% recurrence in a marginal, and up to 50% of recurrence in wide excision, but it decreases with radiation. So we will not, in cases of a malignant, we will never go for a intralesional or a marginal. We'll either go for wide excision or compartmental resection.
Where is this pseudocapsule present, ma'am?
Ma'am, the pseudocapsule is the marginal zone. It is made up of...
So, marginal resection will include pseudocapsule or exclude pseudocapsule?
Ma'am, it will include the pseudocapsule.
Yes. Okay. So, if you already told the recurrence. Okay, fine. So, if even after wide excision, can there be recurrence? So, how much is the recurrence?
Ma'am, 50% recurrence can be there if we are doing only surgery.
Yeah, so it has to be added depending on the, again, histopathology, grade of the tumor and all. Okay. So, when will you do amputation?
Ma'am, whenever there are any contraindications to limb salvage surgery, like for example, if the neurovascular bundle is not, if we are not able to spare the neurovascular bundle and not able to give the functional limb to the patient, yes, ma'am. Whenever, then there are other contraindications, like if there is a pathological fracture, if there is contamination while taking biopsy, if there is a infected wound, if the prior biopsy was taken in a...
So, it will improperly placed scars.
Yes, improperly placed. In this
vertical fracture, improperly placed scar, infection, neurovascular bundle involvement.
And in cases where we cannot give them a functional limb.
Yeah, functional limb is the most important. Okay, first thing you should tell is functional limb. Okay,
ma'am, there is one doubt that I have. Ma'am, in a book I read, ma'am, in this case particularly, they were writing that in cases of in this patient itself, when it's an anterior compartment tumor, a giant tumor which is involving more than one compartment, then we'll not be able to do limb salvage surgery. And if it is going in the inguinal region or the retroperitoneal region, then we'll not be able to do.
Yeah, that's what. See, and there is one line in Davita. Most of the tumors that are there in the upper part of the thigh, you should always rule out abdominal extension. Okay, through the inguinal ligament into the abdomen. Okay, that is one thing. And any more than one compartment, the compartmental excision is not, limb salvage surgery is not indicated. Okay.
Yes.
So, breaching of the compartments is one thing that you will not consider for limb salvage. That's why improperly placed scars. So, that is one indication. Okay, fine.
So, it's a pathological fracture, a contraindication even now, or if it is a limited pathological fracture, well contained, post NSCT,
Yeah.
a limb salvage can
Yeah,
be done.
now the extension of like modified limb salvage criteria, they are not considering pathological fracture like what you told, like in a closed way where we can still excise, they say, but it still is considered as contamination by the old timers. Okay, so you can still, I mean, wherever possible, try to preserve the limb. Okay, limb salvage surgery is indicated wherever you can wherever possible. If it's that's the only criteria that pathological fracture is there, but it is contained. Okay, still you can attempt a limb salvage surgery, explaining the possibility of recurrence in future. Okay. Yeah. So. Okay. What are the indications for radiation? We already discussed, no?
Ma'am, finally, like if some tumor is there and it is planned for a
Somebody speaking. Mute
and
themselves.
if it is planned for NACT, then like we told, like it more than 5 centimeter away from bundle, we can give NART. So how to choose NART versus NACT in such cases?
So wherever possible, see, it's not routinely followed, but ADR and all, they'll give NART wherever possible. Okay, if it is like the field of radiation is decreased. Okay, but one thing problem with RT is that if you give RT in more dose in a young patient, post RT, what are secondary RT tumors?
Ma'am, that includes
Post radiation induced sarcomas or tumors.
angiosarcomas and pleomorphic sarcomas.
No. You are telling RT induced sarcomas. I'm asking what are secondary cancers present? Like why I'm asking is, he asked no. Like when can you prefer RT? Okay, pre-op RT. So dose matters, right? So dose is less in pre-op RT versus post-op RT. So whenever you give more dose of RT, more is the complications. So RT induced secondary cancers. Do you know of anything? Leukemias can occur.
Leukemia. ये भी है ना मैम, sarcomas and all.
Sarcoma.
Yeah, sarcomas, secondary sarcomas or leukemias can occur. So whenever patient has long lifespan, okay, so it is better to reduce the dose of RT if indicated and give it as pre-op. And whenever you see wound complications to extent possible, we can manage it. Okay, but RT is not in our control. So pre-op RT should be encouraged wherever possible, but still it is not widely adopted here. Okay, so not everyone is giving RT. Mostly that Anand Raja sir prefers. Okay, one or two centers outside, they'll give a pre-op RT, but most of them give post-op RT because they're afraid of the wound complications. Yes. Okay, even bone complications are more when you give more RT dose. Okay, so long-term bone complications can also occur. So actually we should give pre-op RT wherever possible, but still not widely followed. Okay.
Okay.
Right. So next, what is that? Yeah, limb salvage surgery we discussed. What is retroperitoneal sarcomas में और कोई important point है? Compartmental excision you already told. What is neurovascular? What is in situ preparation?
I think ma'am it is vessels का कुछ.
We keep the tumor solely on the neurovascular bundle and out of the field and dissect it.
So you can bivalve the tumor, okay, separate the neurovascular bundle, okay, and then you can like whatever is possible, if you are giving intraoperative radiotherapy or cryotherapy, give it and then do the reconstruction. Okay, that is in situ preparation. Okay, but it should be done very experienced centers, not everywhere. Okay. And what else can I ask? Yeah, if it is nearby the neurovascular bundle, Avneet.
Yes.
So, what is planned positive margin?
Ma'am, whenever, I'm not very sure, but I think whenever we are taking, it's based on is it based on the Kawaguchi's principle, ma'am? When we are taking part of the...
Kawaguchi is the margin. Okay, you tell me first Kawaguchi. What was Kawaguchi concept?
Ma'am, it is a concept which is based on barriers. It says that there are thin barriers and thick barriers, and joint capsule is considered as more than 5 centimeters. Thin barrier is considered as a 2 centimeter margin. Thick barrier is considered as a 3 centimeter margin. So, adult periosteum, thin fascia, any adventitia over the vessel is considered as a thin margin, and in infants periosteum, thick fascia.
Thin means how much? Margin should be
2 centimeters.
Okay. Thick is
3 centimeters.
Okay. Joint cartilage comes where and joint capsule comes where?
Joint capsule comes in thick barrier. Joint cartilage comes under 5 centimeters.
So why all this were given?
Ma'am, these were for tumors which were close to the vital structures, and there, by not taking soft tissue margin of 2 centimeters, if we could just take, since the soft tissue sarcomas respects the anatomical barriers.
So these were qualitative margins. Okay. So not blindly everywhere you go beyond 2 centimeters and take the margin. Okay. Qualitative margins were defined by Kawaguchi, which says that when it is near to the neurovascular bundle or tendon, where your functionality of the limb may be in, maybe under compromise, then you can always use this barrier concept for a qualitative margin control. Okay. So you can take this fascia or capsule or adventitial layers, which actually amounts to your more than 1 centimeter margin all round. Okay. Right. So
what is the planned positive margin then?
Yeah, what is the planned positive margin? Now you tell me.
So like
you know
when we are doing when we are attempting limb salvage and we think that this is the only left margin which can be positive R1, we can plan adjuvant along with limb salvage while knowing that this can be.
So you know that
doing R1 resection.
You know that it will be R1. Okay. So your surgery will not aim to do an R0 only at